Everyone, my name is Maureen. I'm a resident from the Mount Sinai Hospital, and I'll be talking about a review of small bowel obstructions in staged IPA procedures. These are our disclosures. The ileal pouch anal anastomosis represents a current definitive surgical management of ulcerative colitis, during which loops of ileum are used to create a functional reservoir that is then anastomosed with the preserved anal sphincter in order to restore continuity of the bowel and provide adequate continence. This was first described in the 70s, and since then, there has been a lot of progression in the surgical approach to pouch formation, including the description of multiple stages through which the procedure can be performed. Patients can undergo a one-stage restorative proctocolectomy, during which they get a total proctocolectomy with IPA construction. There's also an option for a two-stage surgery with a total proctocolectomy with immediate IPA construction with a diverting ileostomy, and then later on an ileostomy closure. They can get a modified two-stage procedure with a subtotal colectomy with end ileostomy, and then a subsequent completion proctectomy with IPA construction, or the three-stage option, which is the one that we most commonly perform at our institution, starts with a subtotal colectomy, then a completion proctectomy with IPA construction and diverting ileostomy, and then finally an ileostomy closure. Most of the patients do really well long-term, but there are a lot of some early and late complications to know about, and among them, small bowel obstructions are the most commonly reported complications, with a rate that can be as high as 44% in the long term. So the goal of our study was to compare early postoperative SBO outcomes between different staged IPAs, and then to further analyze the types of procedures that were required for patients who had operative management of their postoperative SBO. So we did a retrospective cohort review and included all the patients who came to our tertiary care center between 2008 and 2017 with ulcerative colitis and who underwent a primary total proctocolectomy with IPA for medically refractory disease or dysplasia. We had a total of 623 patients, and then we divided them into 4 groups based on staged IPA received. We defined obstruction as a blockage in the small intestine confirmed based on imaging, operation, or clinical symptoms. And then our primary outcomes were early postoperative SBO, which we defined as within 6 months post-op of an IPA stage, and then the rate of readmission and reoperation. And then our secondary outcomes were number of SBOs per patient, readmissions and reoperations, length of stay, and the type of reoperation. And then for the patients who had an SBO, we did a multivariate logistic regression analysis to evaluate risk factors for reoperation and readmission. Most of the patients that we had were in the 3-stage group. We also had about 26% in the 2-stage group, 11% in the modified 2-stage, and 8% in the 1-stage group. Preoperative comorbidities and extraintestinal manifestations were similar between all 4 groups, but patients in the 1-stage group had statistically significantly lower rates of preoperative steroid or biologic use, and patients who underwent the 3-stage or modified 2-stage operation had higher rates of emergent 1st-stage operation compared to the 1- or 2-stage IPAs. So these are our results, and you can see among all of our patients, about 23% of them had an SBO within 6 months of one of the IPA stage. 14% of them required a readmission for that SBO, and 7% of our patients had a reoperation. And when we look and compare our groups, we can see that there was a statistically significant difference between our groups for SBOs and readmissions, but not reoperations. And again, the patients in the 2- and 3-stage groups had the highest rates of SBO, reoperation, and readmission. Then we wanted to take a little bit of a closer look, and we decided to compare the 3-stage patients to each individual stage group size. So we first did a univariate analysis and then a multivariate analysis. And we can see that on univariate analysis, the 3-stage group patients had higher rates of obstructions compared to the 1-stage and the modified 2-stage group, but not the 2-stage group. And that was also significant on our multivariate analysis, with an odds ratio of 3.68 when we were comparing the 3-stage to the 1-stage, and 2.49 for the 3-stage and versus the modified 2-stage group. When we looked closer at the procedures for obstruction, though, this 3-stage group was not significantly more likely to have a procedure for SBO compared to other staged procedures. And then finally, for readmission, the 3-stage patients had higher rates of readmission compared to the 1-stage and modified 2-stage on univariate analysis, but that was not significant on multivariate analysis. And we decided, again, to take a closer look at our SBO patients, and we found that about a third of them required an operative intervention. Among those, 71% had a diagnostic laparoscopy with lysis of adhesion, and 22% required an open procedure. Only one patient had a bowel resection, and that was because of an internal hernia. And then it's also interesting to note that 10 of our patients also had an early ileostomy reversal. So it was not an extra procedure, it was just done earlier. We then compared the different types of surgeries received between our different groups, and we did not find any statistically significant difference either. We did have some limitations. Our major limitation is that the different total observation periods between our groups. So for patients who were in the 3-stage groups, we had at maximum an 18-month observation period, which is different from our 1-stage group patients, and that can account for some of the differences in our rates of SBO. Again, obstruction versus ileus is not always well differentiated in our charts. So when there was only an X-ray or clinical symptoms, we looked at the attending attestation for this in order to determine if the patient had an SBO or an ileus. And we have been performing more and more 3-stage operations more recently, and at the same time, we've been using our EMR better and improving our documentation. So it's also possible that we caught more SBOs in our 3-stage patients just because of better documentation, and potentially the 1-stage or 2-stage patients who had their surgeries performed earlier may not have had as good of a documentation as our 3-stage patients. To conclude, early postoperative small bowel obstructions are common complications of staged IPA procedures. Patients who underwent the 2- and 3-stage IPA had the highest rates of SBO, likely secondary to diverting ileostomies, and a third of patients who developed an SBO then required a surgical intervention, and most of them had a minimally invasive lysis of adhesion or an early ostomy reversal without any long-term implications. So as we saw, about 24% of our patients ended up having an SBO within 6 months of surgery. So it's really important to advise and counsel our patients on the risk of SBO before they undergo their staged IPA. That's all I have. Thank you.